Good morning. Please help me welcome Dr. Christopher Crane, who is an assistant professor in the Division of Trauma and Emergency Surgery. Dr. Crane grew up in Memphis, Tennessee, and then spent his whole academic career in Arkansas at the university, where he received both his MD degree and a master's degree in neurological sciences. He also did his general surgery residency there, and then came here and completed his critical care fellowship here in 2016, and then joined the faculty. This morning he's going to be talking about genitourinary trauma. Dr. Crane.
Thank you very much. So I picked this topic based on the fact that we get a handful of these, sorry. All the way to the left bottom. So I picked this topic based on the fact that we get a handful of this, we see a handful of this trauma every month or so. And based on the strict definition of it, I guess we see it a little more frequently if you consider minor lacerations to the kidney or bladder to be part of in this group. And some of this you may encounter in your general surgery residency or after you graduate and be expected to manage it. As a lot of this can be presented in a delayed fashion. And so knowing the different operative techniques, different plans, and different recommendations for this group of trauma patients will be important. So I have no disclosures. So some background on genitourinary trauma, and here we see the different organs that we're going to basically be talking about. I'm going to focus my talk on the intra-abdominal organs and the kidney, the ureter, and the bladder. We're going to look at a little bit of what to do with some ureteral trauma, but that's going to be very minor focus of this talk. Essentially, about 2 to 5% of all trauma patients have some kind of genitourinary trauma associated with them. About 10% of abdominal trauma alone involves the genitourinary system. And while this is somewhat isolated to the genitourinary tract, a lot of genitourinary trauma is associated with other significant injuries. And specifically in blunt trauma, you'll see about 75% of patients with genitourinary trauma have some sort of other significant injury. And that mapped with penetrating renal artery trauma, you'll see about 80 to 95% of other significant injury seen in the abdominal cavity. So in how to address these and how to address these when you have concomitant injuries is an important role in this field. So over the last decade or so, probably even more than that now, but there's been a evolution in how these trauma patients are managed. This is mainly attributed to advances in imaging and critical care that allow the non-operative trauma to be a hallmark of this group. So because of all these advances and changes in the field, there have been recent efforts to come up with a consensus management for these diverse urological injuries. The World Health Organization and the Society International of Urology did a 25-year review of world literature to look at evidence-based recommendations for management of these patients. In conjunction with that, the European Association of Urology and the American Association of Urology have all come up with their own consensus statements as to how these patients should be managed. And as you can see, with multiple different associations and groups with their different recommendations, the treatment algorithm is complex and can be very varied depending upon which group you follow. So in 2004, the consensus statement was released by the SIU, or the Society International of Urology, that mainly focused on renal trauma. The European Association for Urology released guidelines on urological trauma, which included iatrogenic injury in 2012, and again they revised this to include pediatric trauma in 2014, which was later updated in 2015. Just a look at these different guidelines, the American Urology Association's guidelines that were released in 2014 had 32 different guidelines associated with it. These varied between the European and the SIU consensus statements also. And just looking at how vast these are, you'd see that there's 8 different guidelines for renal trauma in the American Association, 11 for ureteral, 6 for bladder, 7 ureteral, and 7 for genital. And all of these groups use the AAST grading system of organ severity to base their recommendations. So non-operative management for a lot of urological injuries has become well established and followed and documented. But the selection of operative versus non-operative management for these injuries still remains kind of controversial. They tout that there's a paucity of level 1 prospective management studies, and the long-term follow-up is fair at best to see what is the actual best management for these patients. But there are well agreed upon treatment options at either spectrum of the injury, certainly with grade 5 injuries being more lenient towards operative management and grade 1 injuries being more observatory. But the ones in the middle ground are the ones that are still controversial. And given hematuria is one of the hallmarks of genital urinary trauma, and so I looked at specific recommendations based on hematuria alone, and all 3 groups specify that this is not a good correlative to the severity of the injury for genital urinary trauma. Also, it's not specific, as you can imagine, but they do all state that when you do have gross hematuria, that you have to have a higher suspicion for further intra-abdominal injury. So even some of the major vascular or major renal injuries that you'll see, up to a fifth of them will not have hematuria at presentation, and up to half of the ureteral traumas won't have hematuria. Most of bladder trauma will have gross hematuria. And so if you do see hematuria, then you should raise suspicion and may warrant further investigation. So, like I said, I'm going to focus mainly on the kidney, the ureter, and the bladder today. We're going to talk a little bit about some of the urethral trauma that you may encounter as a general surgeon and as a trauma surgeon, but it won't be very in-depth. So looking at different parts of the kidney, the anatomy, the different arterial and venous drainage, and the intra-renal anatomy, which may be important to those who would like to may look at partial nephrectomies or renal salvage surgery. And then what kind of operative options do you have? So a little background about renal trauma. It's the most frequent genital urinary organ to be injured in the trauma patient. About 1.2% of all trauma patients have some kind of renal injury. It is particularly vulnerable to deceleration injuries, and you see about 80 to 90% of blunt trauma will be associated with renal trauma. Or excuse me, renal trauma was seen in about 80 to 90% of blunt trauma. The independent predictors for nephrectomy, when looked at which patients were able to have renal salvage versus having the actual nephrectomy, 2 things were predictive, and that would be penetrating injury and the severity of the renal injury. And looking at the AAST injury severity score, each of these different organs that we talked about, that we're going to talk about today, have grade 1 through 5 injuries. They go from as minor as some subcapsular hematoma as grade 1 injuries, grade 2 injuries being less than 1 centimeter of parenchymal depth, and all the way up to avascular or completely avulsed hilum, which is seen in the grade 5 injuries. So when do you want to take specific images that focuses on renal or genital urinary trauma? And so the three groups did have guidelines that were based on hemodynamic status initially. So first you want to look at the hemodynamic status of the patient and say, well, if they're hemodynamically stable, then we can discuss whether or not to image. Certainly the hemodynamically unstable should be considered for laparotomy. So mechanism of trauma is the second thing that they looked at to suggest whether or not to image these patients. Certain mechanism highly suggestive of renal trauma, such as penetrating injury to the flank or lower ribs, and significant flank ecchymosis may raise suspicion. And hemodynamically stable patients with gross hematuria is another recommendation to get evaluation for these renal patients. Microscopic hematuria alone is not indicated for imaging, but with hypotension should raise suspicion. So what imaging to order? The IV pilogram was considered the gold standard for a long time before contrast CT scans became so prevalent. Currently, they recommend doing contrast CT scans with delayed imaging to evaluate these patients. And it's about up to 98% accurate. Not only are you looking for what kind of trauma happened to the area of interest, but also you want to look for other injuries that may be associated with the renal trauma and also evaluating the other kidney. So the IV pilogram still does have its use, and they discussed its function to be used in the operating room if you want to evaluate the other kidney before completing your nephrectomy. And essentially what you do is you give IV contrast with the plain films of the abdomen in a delayed fashion about 10 minutes later to evaluate the other kidney. Angiography, all three groups discussed angiography in different recommendations. Some more favored angiography than others. The SIU, for instance, had a more lenient stance towards angiography, where the American Urological Association did not. But it's good for evaluating renal artery, renal vein injury, and it can also be used as embolization or stenting if indicated. Ultrasound is not recommended for evaluation of the kidney, as and 1/3 of these will have a false negative rate for injury. But you can use it to evaluate to see if there is a second kidney and to see if it is functioning using Dopplers. MRI may be indicated in patients because of the sensitivity, which is very similar to CT scans, but it's more recommended for the follow-up studies if you want to prevent giving more contrast to your patients and to follow the injury severity in the future. So with the location of the kidneys and the retroperitoneum and abutting other major organs, there's a very high likelihood that there's a possible injury to another organ or organ system when you're dealing with renal trauma. And it's stated that about 95 to 99% of gunshot wounds to the kidneys will have some other associated injuries. And 60% of stab wounds will have another associated intra-abdominal injury. And even with blunt trauma, there's still 1/4 to 1/3 of the patients that risk injury to non-urological structures in the abdomen. Just based on its location, the right kidney, less protected by the ribs, is a little bit lower than the left kidney. The diaphragm is closely associated with both kidneys and has a high injury rate in penetrating renal trauma. The left kidney, as seen here, it's abutted by the tail of the pancreas, the stomach, the splenic flexure of the colon, and the aorta is a little more closer to the left kidney than the right. Also, the fourth portion of the duodenum lies in that area. The right kidney, flanked by the liver, the IVC, the fourth portion of the duodenum, and something else to be aware of is the portal triad that can lie lies anteriorly to the kidney. The intra-arterial or intra-renal arterial branches have 5 different branches that supply the kidney, and These may branch early from the aorta and will be seen as accessory renal arteries. They're you should be aware of these, especially when trying to undertake a partial nephrectomy, and the fact that different arterial branches will supply different parts of the kidney, and so something to be aware of. The renal hilum, most commonly you'll have a single artery and a single vein that is seen at the renal hilum, and it's typically organized with the renal vein being anteriorly to the renal artery and then to the renal pelvis. The venous drainage of both kidneys is variable. So the right and left, the right side of the renal vein is much shorter and drains directly into the IVC. The right gonadal vein, as you can see at the very bottom inferior portion of the diagram here, drains directly into the IVC, and as does the right adrenal vein seen superiorly here. These are things to be aware of when performing your nephrectomy, if necessary. Oftentimes, also posteriorly behind the renal pelvis, you'll have lumbar veins that will drain into the posterior aspect of the renal vein as well. So, the left kidney has venous drainage that is more variable than the right kidney, and the adrenal vein will drain directly into the the left renal vein, as well as the gonadal vein that's seen inferiorly here, drains directly into the left renal vein. You also have lumbar veins that drain posteriorly, and with all this extra venous drainage, you have a chance of kidney salvage if you ligate the left renal vein close to the IVC. These studies have been done mainly in trauma and also in AAA repair studies, and it's anywhere from 85 to 95% success rate when renal salvage rate, when you ligate the vein close to the IVC. The right kidney, on the other hand, will develop venous congestion and will lead to nephrectomy. So some of the aberrant renal anatomy, a well-described retroaortic left renal vein can be seen. It's seen in about 1 to 2% of patients, and there's 4 different types. And it's something to be aware of that this drainage can occur lower into the iliacs. It can have a kind of a collar drainage where you have both anteriorly and posterior retroaortic drainage of the left renal vein. This is important to be aware of at the time of operating, or even when you're planning an operation if you have the time. So, operative management. So you decided to operate, and the controversy in this lies on whether or not to gain control of the renal hilum prior to renal exploration. Now, sometimes this is relative to what kind of trauma you're dealing with, and if it's a gunshot wound to the mid-abdomen, you may not have the opportunity to, or you may not know, you may be exploring the aorta or the IVC looking for an injury and tend to get control then. Proponents of the operative or control of the renal hilum prior to getting to exploring your kidney state that there's reduced nephrectomy rates when you do get vascular control. Others state that it's operative time that's unnecessary and that control can be attained at the kidney at the time of exploration. But the bulk of the literature would state that otherwise unnecessary nephrectomies is prevented when you do get vascular control prior to exploration. There is a published group in the Journal of Trauma. This is actually published in 1999, but it has been repeated a couple times, to looked at age and trauma-matched controls, looking at whether or not to get vascular control or not get vascular control prior to exploration. And the the groups varied in only in operative time. The blood loss was about the same. There's no statistical significance, and there's no statistical significance into how much transfusion they did receive. And so from this, they stated that vascular control may just spend more time in the operating room that they necessarily might not need. So if you do decide that this is the exposure, or you do have to embark on this before your exploration of the kidney, this is one point where the anatomists are a little bit more optimistic into their drawings and to how the operative procedure is performed. But essentially, it's suggested that you lift the transverse colon superiorly, move the small bowel to the patient's right, and then by the inferior mesenteric vein and the ligament of Treitz, you incise the peritoneum. And there you should be able to retract the pancreas and the duodenum to the side and be able to get control of the renal hilum. Much easier said than actually performed, as this area is very congested with neurovascular bundles. And then after you get control, you want to proceed with your medial visceral rotation. Other surgeons state that they get adequate control by just doing the Cattell-Brash itself. As you can kind of see in the middle picture here, that once you're able to free up all the small intestines and the right colon, that once this lifts superiorly, that you can still see the right renal vein, right renal artery, and the left as well. Either way, it's going to be based on your operative judgment as to whether or not either method works for you. So the renal the kidney has a thin but durable capsule surrounding it that can help with hemostasis and repair of renal injuries if partial nephrectomy is entertained. The anterior surface of Gerotis fascia is a good starting point to evaluate the kidney. They do recommend that you start in an extravascular plane free from where the injury has occurred to avoid stripping the capsule from the kidney that may still be intact. And if partial nephrectomy is considered, then it's important to control hemostasis, but also to remove devitalized tissue. It's important to note that other concomitant injuries that may be seen with the renal injury does not change the indications for renal salvage, in that you still may be able to perform this procedure even if you have colonic contamination or small bowel contamination. Some things that can be seen from this diagram is they recommend removing the devitalized tissue. In this instance, they did get control after mobilization, but using the thin capsule to suture either a piece of an omentum or even a piece of gel foam that can be helpful in getting hemostasis. Other things is it may be helpful to mobilize the entire kidney so that you have free ends or tension-free repair of the capsule in doing this closure. It's important also to close Gerotis fascia, close some kind of layer separating other visceral organs from this repair, as that may increase your risk for urinoma, urine leak, and further bleeding. So who do we operate on, who do we not operate on? That's still a question in the management. It's been well accepted that low-grade renal injuries can be managed non-operatively with high success rates, but in the middle ground is where the controversy lies. So there are indications that are generally accepted for exploration of the renal injury, and those are hemodynamic instability, and a lot of these are no-brainers. But some groups would entertain the idea of possibly doing angiography for control. Certainly not in the hemodynamically unstable patient, but in some of those that maybe have a hematoma that may be slightly expanding, or that you may have avulsion of the or excuse me, that you may have ongoing hemorrhage that is slow to correct. So what are the relative indications for operative management? And again, this varies based on what recommendations you look at and based on your operative experience. But some recommend that it's a relative indication if you have a high-grade injury. That's not very specific. It's very, very vague. Large perirenal hematoma, the presence of urinary extravasation on contrast studies, and a significant form of devitalized parenchyma that's seen in the CAT scan. These also may be indications for angiography, as you may be able to embolize and then have delayed operative management. There is a general trend towards non-operative management in even in this group of patients, because some groups will tout that there's a renal salvage is actually better if you avoid exploring these patients, and over time they'll heal their injuries. In looking at angioembolization success rates, it's certainly more successful for the lower grade injuries, but that means to say that maybe they didn't need any operative intervention at all. The grade 5 injuries, though, has about a 50% chance of failure, and they have many more complications as a result of this too. So the ones that do suggest a more aggressive surgical repair do state that you have a decreased risk of postoperative complications, urinary leak, infections, hemorrhage, and this does allow for appropriate drainage to be placed at the time. It's generally accepted that blunt avascular or penetrating lesions of the renal vascular pedicle, grade 5 parenchymal injuries, and uretero-pelvic avulsion or complete avulsions of the fornices be managed operatively, and these patients do much better. So I'm going to shift gears a little bit and talk about the ureters. So we're going to look at the anatomical location, the vascular supply, the different repair options, and then kind of towards the end, I'm going to talk about more damage control options that are available. So luckily, the ureter trauma is rare. It's seen in about 1% of patients with genital urinary trauma, and about 4% of penetrating abdominal trauma does involve the ureter. There's a high risk of other concomitant injuries being seen when you do have ureter trauma, and hematuria may be absent in 15 to 45% of these patients. Something to also note that ureter injury is one of the most commonly missed injuries at the time of laparotomy, within maybe 2/3 of the intraoperative ureteral injuries being missed at time of laparotomy. So the consensus statement that was released by the EAU addressed iatrogenic trauma to the ureter, as this is the most common cause for ureteral trauma seen in urology, OB, colorectal, or vascular surgery. And the distal 1/3 of the ureter is the most common site of iatrogenic injury. In reviewing the literature of the patients that do sustain ureter trauma, these patients do fare better with operative repair compared to non-operative management. But, delayed repair has been successful and has been looked at successfully in the damage control setting. So, ureteral trauma diagnosis. Very difficult to diagnose when not in the operating room, but a spiral CT with delayed images, and if you look at the failure of the distal ureter to opacify, then you have a high suspicion for injury. Other ways to diagnose: cystoscopy with retrograde pylography. This is a good way to diagnose the injury, and it may be useful also in a therapy by possibly placing a stent. This will also save contrast that may have been given already and could confound the renal injury. In the operating room, methylene blue can be given, and you can evaluate the extravasation of blue urine. And then delayed symptoms that may have a high suspicion of ureteral trauma: fevers, increasing creatinine, hematuria, flank pain, and sometimes this is even seen first with a prolonged ileus that may raise suspicion for some other kind of trauma. So in evaluating the ureter intraoperatively, it's important to isolate and visualize the ureter running in its course. Like I said earlier, you can give indigo carmine or methylene blue. And then in the operating room, you can do a retrograde ureteral pyelogram, which can also be used for possible stent placement. Looking at the AAST organ injury severity score for ureteral trauma, and this from grade 1 to grade 5, grade 1 being just a small hematoma without any kind of devascularization. Grade 2 injuries is a transection of less than 50%. Grade 3 is a transection with greater than 50%. And then a complete transection with greater than 2 centimeters of devascularization is considered a grade 4, with greater than 2 centimeters of devascularization being a grade 5. So most grade 1 injuries can be treated non-operatively or can be useful in placement of a stent. Grade 2 injuries, it's recommended that you repair these over a stent with absorbable suture to prevent stone formation. The different types of iatrogenic injuries could include suture ligation or crushing injuries. These may only require a stent, but they can be delayed in their presentation, and they may require some form of reconstruction. Thermal injury and devascularization is usually presented in a delayed fashion as well, and you'll see urinary leak and stricture formation from this as well. The attempt at placing a stent is feasible, but may require reconstruction with exploration. So the transection of greater than 50% usually requires you to excise the edges and do complete reconstruction over a stent. Looking at the course of the ureter, and the ureteral course may be confusing, it may be misleading as hematoma, or even in severe infections that you can be seen may alter the course slightly of the ureter, but usually crosses in the retroperitoneum posterior to the colon and anterior to the psoas muscle. It will then cross the iliac bifurcation, here as seen in this diagram, and it will follow the internal iliac artery into the pelvis and drain into the bladder. So one of the things I remember from the anatomy course is that the ureter will cross the water under the bridge. And in males, this will be posterior to the ductus deferens. As you can see, this is the posterior view of the bladder here. If you can imagine, anteriorly, the ureter will cross posterior to the ductus deferens. In the females, it will cross posterior to the uterine artery. It also passes posterior to the testicular and ovarian vessels. It has a close relationship to the uterine artery and may be injured in hysterectomies without recognition. So the vascular supply for the ureter is very vast, convoluted, and comes from many different places. Superiorly, it will have branches from the renal artery as well as the suprarenal artery. It'll have direct branches from the gonadal artery as well as the aorta, and then you have smaller branches and smaller vessels that will supply its course in the pelvis. That mainly comes from the internal iliac artery. It's important to note that the vascular supply of the ureter in a microscopic depiction runs in the adventitia, and it's important to not devascularize this area by too aggressive of manipulation of the ureter. So, how do we treat the ureteric injury? It's based on severity and location of the injury. As you can see in the diagram looking at the distal ureter, the blood supply is much more convoluted and diffuse, and will have smaller vessels that are going to contribute to the blood supply to the ureter. And so most of these are going to be, you're going to try to prevent any tension on your repair, as well as using a stent to buttress your repair and also help with urinary drainage. And then also using absorbable suture will be important to prevent stone formation in the future. So approximately you can have an injury that's near the renal pelvis, and some of these injuries may be amenable to direct repair with a stent. After mobilization, the kidney allows there to be tension-free repair on your, or tension-free to be on your, tensionless on your repair. And it's recommended to repair this over a stent. It's important to note that you can get about 5 to 8 centimeters when you actually mobilize the kidney for this type of repair. Direct ureteroureterostomy is recommended for some proximal and middle ureteral injuries, but the distal injuries have such a tenuous blood supply that they have a high likelihood of failure and urine leak and stricture formation due to this. So it's more recommended for the middle and proximal injuries. It's important to remove any devitalized tissue, spatulate the edges, and then again repair with absorbable suture over a stent. Some common complications that can be seen from this is urine leak, which it's more commonly published as about 2 to 5% complication rate, but it can be seen in up to 10% of some studies. And then a ureteral stricture can be seen in about 5 to 10% of these cases. Most of these are just amenable to a further stent placement and longer stent placement. Another repair that can be entertained, and this is seen in mainly the middle ureteric injuries, but you can perform a trans-ureteroureterostomy, which essentially means that you're going to swing the injured ureter over to the non-injured ureter and repair this over a stent. There is a higher complication risk with this, and the complication will also could involve both kidneys. And so you started off with one ureteric injury or kidney that's injured, and then you may end up with complications that involve both. So when to consider this, and it's often considered when there's a large or long segment of the ureter that's injured. And it also may be, if you're trying to avoid going into the ipsilateral pelvis for whatever reason, if there's concomitant infection or previous radiation or something, this may be entertained as well. The distal ureter is usually either managed with direct reimplantation into the bladder. This may not be able to occur as to the length of the injury that has occurred. And so what is recommended is another treatment option is the Psoas Hitch. And this, you mobilize the bladder and you typically will fill the bladder with saline. And then make a transverse incision in the bladder and use this to stitch this to the psoas muscle. And hopefully this will provide a tension-free repair for your ureteral bladder anastomosis. So one of the things that they do discuss in this repair is that when you have this posterior mucosa here, you may be able to, under direct visualization, open this posterior mucosa and tunnel the ureter through and make your anastomosis lower in the bladder. And this may help with reflux of urine in the future. Typically, these are repaired as well over a stent. And one of the key things in the operation, you try to avoid the genital femoral nerve that's lying anteriorly on the psoas muscle. The Baori flap is another option that you have for the distal mid to distal ureteral injuries. And this has a higher complication risk with urine leak and stricture than the Psoas Hitch alone, but it can be performed in conjunction with the Psoas Hitch to allow a tension-free repair. And essentially what you're going to do is make a longitudinal incision in the bladder and use this piece of bladder to create this tunnel structure that will act as your distal ureter and then repair the bladder primarily. So when looking at ureteral trauma, some things to note is that stents do not actually reduce the incidence of ureteric trauma. They do help to identify injury when it does occur, though. And it's important to identify the ureter at key anatomical points and have a high index of suspicion for certain traumas that occur in the area. And also when performing certain procedures such as a hemicolectomy or a hysterectomy, it's important to note that this is a common complication from these operations, and the ureter should be visualized to attempt to avoid it. And then also avoid too vigorous dissection to prevent devascularization of the ureter. So next, in looking at the bladder, bladder trauma, it's seen in both blunt and penetrating injury. And there's a high incidence of patients that have bladder trauma that are associated with pelvic ring fractures. The cardinal sign for bladder trauma is actually hematuria, as greater than or equal to about 95% of patients with bladder injury will have gross hematuria. And then some key signs that may have it high on your differential is inability to avoid lower abdominal pain and suprapubic or perineal ecchymosis. So its anatomy is situated in the pelvis. In the pediatric population, it's still an intra-abdominal organ, and so it has a higher incidence for blunt trauma, being a relative risk for bladder injury. In males, it's anterior to the rectum, and females anterior to the uterus. And then the muscular layers seen here, there's multiple layers of detrusor muscle, making it a thick muscular organ. There is a layer of adventitia that surrounds the dome of the bladder. And then the ureters will cross in a posteriorly, inferiorly, and drain into the trigone of the bladder, which is important to note. And if you have bladder trauma and you want to do your repair to avoid the ureteral's entry into the bladder. So the AAST injury severity score, grade these 1 to 5 like the rest. Grade 1 involve partial thickness injuries. Grade 2 is usually extraperitoneal with less than 2 centimeters. Grade 3 laceration is extraperitoneal or intraperitoneal extraperitoneal greater than 2 centimeters or intraperitoneal less than 2 centimeters. And then grade 4s are intraperitoneal, and grade 5 is when it extends into the trigone. So CT cystogram is the best way to diagnose the bladder injury, and it will help distinguish between intraperitoneal versus extraperitoneal injuries. Non-operative management for extraperitoneal injuries was described well by Correa et al. And has been followed since the early 90s. And a large bore catheter is typically the only management strategy that you'll have for the extraperitoneal rupture. It's important, though, that you may have to flush the catheter, as hematoma may prevent drainage and complicate your management. Typically, they suggest that you repeat your cystogram about 10 to 14 days after the injury to evaluate for bladder healing. Typically, if the bladder injury is still seen, you want to give another 10 to 14 days with the Foley catheter, and over 95% of these will be healed at 28 days. Intraperitoneal bladder rupture. These are generally managed operatively, and for multiple reasons. One is to fix the bladder and repair and prevent urine from leaking into the abdominal cavity, but also there's a high incidence of associated injuries seen in small bowel, uterus, and even in the rectum. And it's important to note that you want to repair these in at least 2 layers. Some urologists actually repair the bladder in 3 layers. But it's important to separate your repair from any other concomitant injuries that may have had subsequent repair, such as your rectum or even small bowel. If you can lay some momentum over your repair, this will help prevent fistula formation between your repairs. So one of the first things that urologists, when I operated with them in my training, is they would come in for to help fix the bladder trauma, and they would anteriorly mobilize the bladder out of the space of retzius, and they would typically do this to help prevent any tension on their repair. This tension is also relieved by the large bore catheter drainage, but you know, with hematoma and other things that may complicate the drainage. It's important, if you do have some bladder injury that you are operating on for repair, to evaluate the intra-bladder anatomy to ensure that you're not near the trigone of the bladder, or you can address the ureters if that's necessary. So a little bit on damage control principles in genital urinary trauma. This can be done with high success rates with the exception of major active bleeding or avulsion of the renal pedicle. But hemorrhage control, once it's obtained, you can pack the kidney or pack the area in question, and then bring them back to the ICU to correct their temperature, coagulopathy, and acidosis, and plan for a renal construction at the second laparotomy, if that's possible. Ureters, percutaneous nephrostomy tubes can be used as an adjunct. Also, another key thing is in the unstable patient that you do notice they do have ureteral trauma, you can place a stent and externalize this through the skin and hook this to a Foley catheter, and then plan for repaired, formal repaired once they're more stable. Bladder injuries can be missed and can be difficult to assess due to hemorrhage and other contamination. And percutaneous nephrostomy tubes may be an adjunct for this as well, and quickly sewing in a suprapubic catheter may be another thing that you can utilize in this patient population. And so this is really the only